afternoon, everybody. Today I'll be discussing about antiplatelets. Whenever I think of antiplatelets, the first thing comes to my mind is a native phrase that is nip in the bud. Means to stop something before it has an opportunity to become established. That is what exactly we are doing with the antiplatelets, with the help of antiplatelets. So we have platelet plug formation. Before discussing about the antiplatelets, let's just briefly revise about the platelet plug formation so that you'll get a basic idea. Okay. So there is a vascular injury, the collagen gets exposed, then the von Willebrand factor will get released and get attached to the collagen, and the platelet gets attached to the von Willebrand factor through the GP1B protein. Then simultaneously the nitrous oxide and prostacyclin release will be reduced from the epithelial cells. Nitric oxide and prostaglandins is responsible for the vasodilation and to keep the platelets inactivate from the platelet adhesion. Then the platelets comes and attached to the von Willebrand factor. From the platelet, from the alpha granules, 5-HT, that is serotonin, gets released, ADP gets released, and the metabolism of thromboxane A2 will start from the phospholipid layer of the platelets. So 5-HT will actually cause the vasoconstriction through the smooth muscle, and the ADP and thromboxane we'll see, but before we'll see about how thromboxane gets metabolized. From the phospholipid layer of the platelets, there is fatty acids called as arachidonic acid gets released. So the arachidonic acid will get converted into PGG2 and PGH2 through the enzyme COX, that is cyclooxygenase enzyme. Then the PGG2 or the PGH2, H2 will be going and converted into the PGI2, which is called as prostacyclin, which helps in the vasodilation actually. But this will get inhibited. I mean, when there is a vascular injury, this will be getting inhibited. Then the thromboxane A2 synthesis will start initiating. So the thromboxane A2 will be getting synthesized through the thromboxane synthase, and it will help for the aggregation of the platelets. Now coming to the platelet, we have thromboxane A2 receptor. The thromboxane A2 will come and attach to the thromboxane A2 receptor, which will activate the GQ pathway. So the GQ protein will actually stimulate a membrane bound protein, that is PLC. This PLC will break down the PIP2 into IP3, that is in acetyl phosphate, and DAG, that is diazyl glycerol. Then the IP3 will stimulate the endoplasmic reticulum, in which it will stimulate the protein channel, which will cause the release of calcium. This calcium will again go and stimulate the alpha granules, which then fuses to the platelet membrane and release 5-HT, ADP, and it will more release of thromboxane A2 and plus calcium. This calcium will be getting utilized for the coagulation cascade. Now the PKC, that is this route, the DAG will stimulate the protein kinase C, which will stimulate the GP2B3A. Using this glycoprotein, the platelet will get attached to one another through a glue called fibrinogen. So this same pathway comes here also when the ADP, which is released, coming and attaching to the P2Y2, same pathway like GQ pathway will get activated. Additionally, we have G inhibitory pathway, where the G inhibitory protein will go and inhibit the acetyl adenocyclase. Okay, this enzyme is responsible for the conversion of ATP to cyclic AMP. The cyclic AMP breaks down the protein kinase and helps in the phosphorylation of VASP into VASP-P. So the VASP is active and VASP-P is inactive. We need the VASP active form for the stimulation of the glycoprotein 2B3A. So we need VASP as it is. So we will inhibit the conversion of ATP to cyclic AMP, thereby we will keep the VASP as it is. So it will help for the stimulation of GP, 2B and 3A. Then we have an additional enzyme, that is phosphodiesterase E, which will also break down the cyclic AMP, which will convert the VASP to VASP-P, which is our inactive form. So we will block the PD3 also. So coming to the classification, we have thromboxane A2 synthesis antagonist. So the aspirin will be acting on the COX. It will inhibit the COX, thereby it will inhibit the synthesis of thromboxane A2. So the additional steps won't be happening. Then we have P2Y12 receptor antagonist. Coming to aspirin, it is the first drug which was identified as antiplatelet. It was first found in 1899, I think, for fever and pain. But later on, they found that aspirin is very good for the prevention of thrombosis, and it reduces the risk of stroke and heart attacks. So they started using aspirin as for the antiplatelet activity. It was followed by the ticlopidine, which is not now used due to its bone marrow toxicity. But an analog of ticlopidine, that is clopidogrel, was developed in 1990s, and now it is being used, and the combination of aspirin and clopidogrel was found out to be effective in treatment of ACS, that is acute coronary syndrome, by 2001. So they started using the combination from then on. Then other drugs are there, like ticagrelor, prasugrel, from the class P2Y2 receptor antagonists. So this will inhibit the binding of ADP to P2Y12. Thereby it will inhibit two pathways, like G inhibitory pathway and GQ pathway. So this stimulation of, the production of GP2B3A protein won't happen. So the attachment between the platelets won't take place. Now we have the actual GP2B3A inhibitors, which will inhibit this glycoprotein. Thereby it will prevent the attachment of two or more platelets together. Then we have PD3 inhibitor, which is responsible for the breakdown of cyclic AMP, which will cause the active VASP to become inactive VASP. So we'll inhibit the PD3 enzyme, so that will prevent the conversion of active VASP to the inactive, and we'll keep it as VASP. Okay. Now that is dipridamole and cilostazol we have, and GP2B3A we have abiximab and tirofiban eptitibide. Now the mostly used antiplatelets are aspirin, clopidogrel, ticagrelor. Usually you can see in a hospital formulary also ticagrelor, I think 60 mg and 90 mg is there. Then clopidogrel 75, aspirin 75 to 150 shows the antiplatelet activity, so you can use that. If you are giving more than that, the aspirin will inhibit the COX-2. So you will keep the dose in 75 to 150 there. Now coming to the indications, we have ACS, that is acute coronary syndrome. It will be used for that. PCI, that is post-percutaneous coronary intervention. That is, it's a procedure which will remove the plaque or clot, anything, use stenting. Then you can use for a stable angina. Then acute ischemic stroke also you can use. Essential thrombocytosis, that is in the patient's body, it is thrombus formation is happening due to some reasons, and you can use for that also. Then primary prevention of coronary artery disease, atrial fibrillation with an increased risk of stroke. Then to prevent the primary prevention of venous thromboembolism. These are some of the indications. Then the adverse effects, like areas you can probably see is epistaxis, gingival bleeding, that is gum bleeding. Then petechiae, purpura, melena, hematostasia, and vaginal or urinary bleedings. Then coming to the contraindications, we have you can't use, better not to use in large esophageal varices. Then if there is a history of intracranial hemorrhage, then significant thrombocytopenia, if it is there, better not to use, and major surgery within 72 hours, preferably not use that. Then hypersensitivity, that especially will be focusing on the aspirin, because it is salicylates, so maybe there is a hypersensitivity. Then we have CHF. In that, cilostazol is not preferred in CHF and patients with asthma. You can't, better to avoid. Coming to the monitoring, just check for the bleeding risk, but it's not necessary you should check for it. If there is a massive gastrointestinal bleeding and all, better avoid the antiplatelets. Then discontinue clopidogrel and ticagrelor before 5 days, before a major cardiac surgery or non-cardiac surgery, and the prasugrel before 7 days you should discontinue it. I think that covers most of this. And silostazole, due to its PD3 inhibition action, you can use for peripheral artery disease. I mean, you can use PEDs. You can use for that also.